it's my pleasure to be here, to have been invited to that prestigious conference, which gives a start to the robotic program in very advanced Indian surgical centers. I try to give as much as contents as I'm able to give, and I try to start with an apparently small topic, but nevertheless important and sometimes difficult topic, which I included because within 4 hours we should have time enough to focus on several aspects. The ectopic mediastinal parathyroids. If I may, I would summarize our experience. I see very skilled endocrine surgeons being with us, so it should make sense to include this topic. And I just recently had another time to focus on that topic because we are about to write a book chapter for the ESTS. The ESTS, the European Society of Thoracic Surgery, will work on a comprehensive book on all aspects of thoracic surgery, and in that case, it was my task to talk about the thoracic part of the thyroid and the parathyroids. And today I just want to focus on the parathyroids. The whole topic of hyperparathyroidism leads us to either secondary or primary, similar but very different. In the case of primary hyperparathyroidism, we expect in most of the cases one adenoma, or in rare cases multi-hyperplasia disease. This can be demanding. I myself did not only read about it, and I ask you, we are about to being very interactive. Who had the case in the OR that that it was not corrected after removal of the first gland, and you had to go on to the second or the third gland? I had such a case with 3 glands, and then it was done. Multi-glandular hyperplasia. On the other hand, we only operate in renal secondary hyperparathyroidism in that secondary cases. And now we expect, in most of the cases, typical neck locations. If not, if something happens, if there is a persistence or recurrence, or in rare cases there's no typical anatomy, then we have the case of ectopic parathyroid glands as a question. And I try to focus on these cases, these mediastinal ectopic cases. Of course, we have in mind that not all of the ectopic positions are in the mediastinum, in the thoracic cavity. A lot of ectopic positions are to be expected in the neck, deep in the neck, paraesophageal position, paravertebral position, and so on. But 2/3 of our ectopic mediastinal glands are to be expected in and around the thymic area, and therefore here you have the connection with a thymic gland. We were looking. This is a little bit back. I'll get you the latest data, but altogether the picture did not change very dramatically. That in a 15 years period we had only descriptions of below 100 patients, mainly being case histories and only a few reports including a little bit more patients, as you can see here. And I think we even included in that report two of the latest publications. So this is not anymore 2009. Here you can see two of the latest publications. This is the work of Joshua Sonnet and his group. We tried to put all our experiences together. Then the STS did not accept the abstract last year, and everyone published his experiences. But this is a 4-center approach, looking back at 15 years, 4 American centers, 15 patients. And another report, also a long time, several centers, 13 patients. This is not too much. So you have the numbers. And we are grateful to these Austrian surgeons. Some of you know Thomas Schmid, and we know Bodner, Schmid, the whole group. They did for the first time a robotic mediastinal resection for a parathyroid. They had a transient nerve lesion, which resolved in the end. They used 5 trocars, and it was a little bit complicated position of that parathyroid, but it was the first approach. Meanwhile, as to the robotic experience, and this is our topic today, because we think there are some real advantages of this technique, especially for these ectopic glands too. And here you can see only case reports again, but more than one, and a shorter period, of course. And we were lucky to have 5 patients and now 6 patients, meanwhile, to be reported with, for my opinion, difficult pre-case histories. The whole story can be best illustrated in the description of a few patient case histories. What we tried to focus on was the pre-operative workup. How should that be, not only with ectopic parathyroids? In my opinion, it's of special significance to have always a scintigram for the parathyroids in every kind of PTG to be resected, because if you lose the information that there could be, or there will be definitely, a mediastinal ectopic parathyroid, then you might be wasting hours in the neck, and you won't solve the problem. So we routinely have these laboratory findings leading to that cause. Then we have, of course, a ultrasonography, which may or may not be successful. It depends, clearly to be stated, it depends on the experience, the skill of the investigator, and on the position and the size of this parathyroid. We, as I mentioned, we definitely require a PTG scintigram, and in these cases, undergoing a potentially ectopic resection, we want to have one kind of scanning of the CAT scan or MRI. Special significance may have the instrumented image fusion. I will explain when that is required, necessary, or wanted, and why. Here you have our our 5 patients, as you can see, we had as well secondary as primary indications. We had different localizations inside the thymic gland, para-aortic, not to be related to any organ, and directly at the aortic arch. And we had as risk factors of maybe to be named a little bit more difficult, previous sternotomies, in one case even 2 sternotomies, complications with the HPT, 2 cervical explorations. In that patient, really 18 hours were spent to resect a gland which was not found. Between the first and the second operation, there had been the scintigram showing a mediastinal gland, and they tried again to get it from the neck, but unsuccessfully, and then there was a very easy operation with the thoracoscopy. Let me illustrate it a little bit. What does that mean? How are these patients? Here you have you had, of course, a typical secondary hyperparathyroidism as the indication. Years back, this developed. Then the first operation was a 4-gland approach with simultaneous replantation of the parathyroid in the lower extremity. 4 years later, there was a recurrence. With that in the history, it should be a surprise, pointing to something strange, maybe in the mediastinum. Therefore, the first idea in such cases should be explantation of the implant of the lower extremity, and it helped for a while, but it covered only another pathology. Again, 2.5 years later, another recurrence with that very high values of PTH, and then the analysis showed this lesion, large lesion, could be focused with no other diagnostic measure, but nevertheless, to plan the operation, I would not recommend to directly operate, even if it's large as this and clear as this, with these facts of the history in this patient. And look, this was the CAT scan analysis with maybe you see it here, with a direct vascular supply from the aortic arch and positioned a little bit between the supra-aortic arteries. And these pictures now look a little bit easier. There were adhesions of the lung to be taken away, and then we saw this picture at the aortic arch, and you may imagine, this is my point, one of the points with that topic, you may imagine that with only straight instruments, it would have been by far not as good, not as easy to dissect directly in that area. Nevertheless, we lost in that patient 700 milliliters of blood. It was a demanding operation, but never insecure for the patient because of the Da Vinci technique. Quite an advantage. All of you with experience in thoracoscopy or laparoscopy will understand that how beautiful the resection may be with the angle tips of the instruments. A second case, again, kidney insufficiency as the indication, secondary hyperparathyroidism. First operation, a 3-gland parathyroidectomy together with thyroidectomy. You know, we have 3 ways, 3 different strategies: 4-gland approach with simultaneous replantation, 4 glands resection without replantation, and the third one is 3, 3.5, 3 3/4, which is reserved for the younger patients with us in Europe and Germany, for the younger patients expecting a transplant in the near future, and then the pathology is resolved and the natural position of part of one of the parathyroids may be enough for a normal life. But in this patient, this was a persistence. The definition is with us within 6 months. Again, the disease means a persistence in comparison to a recurrence if it comes back later than 6 months. And the second operation was an upper sternotomy with extirpation of an ectopic mediastinal 4th gland. So we had removed all 4 glands. But again, 2 years later, a recurrence occurred. And now you had this picture, scintigram. Keep in mind that this patient had been with a sternotomy for the removal of the 4th gland, and this was the position. And here is my tip for the tips and tricks lesson. We measured, in that case, we exactly measured at the surface of the patient the distance in the CAT scan. Exactly in that position we would put the patient in the OR. And then again in the OR we exactly measured and found the point where to go. And now again with a robotic Da Vinci system, you may, as you know, you may focus and fix the position of the camera and then the instruments exactly to that position, which is an advantage as compared to any trial of handmade positioning. And I only, I admit I did not find the video, which is 3 minutes. You may imagine here, we saw a gray wall after the sternotomy. Nothing was normal in the mediastinum, but we were encouraged by the measurements to go on into this area, and as you can see here, 2.5 centimeters of distance, and then we exactly found the gland, which was not very large, so you could not palpate or indirectly palpate that, but you had to find it, and it was a straightforward operation because of that measurements and the diagnostic and ectopic 5th gland in that case. And for illustration of the imaging technique, I want to show a 3rd case with a history of a subtotal thyroidectomy, then years later, 8 years later, complicated primary hyperparathyroidism with a sonogram and parathyroid scintigram with no evidence of anything ectopic. But with the analysis, you can see this is the illustration of the more difficult cases with small lesions and not very, if you are not very sure what to do in these cases. We knew that there had been an operation with a probable partial resection of some of the parathyroids, and now very indirect hint to mediastinal pathology. And the CAT scan again was such a small lesion, which is now, seems to be a little bit more clear, but the papers I showed at the beginning of 2010, 2011, the largest experiences we have with 13 to 15 patients, they had a failure rate which is very high. Let's say very high. 3 of 15 patients could not be resolved. So the most modern strategy, everything known, and so on. And because of what? The reason was in all 3 cases an incomplete diagnostic workup. And the strongest recommendation of this paper, I think it was published in the Annals even, was to have a complete workup. And as, well, let's say, all the efforts you take before you enter the mediastinum should be worthwhile in all the cases. And now we try to automatically have a fusion imaging, just like PET CT scan with that MPI tool. And here you can see how that fusion was really obtained. And after that, we were very sure to have a partial thymectomy with resolution of the problem. Here inside, with a partial thymectomy, was the parathyroid. As to the results, we never used more than 3 trocars. We had left or right approaches as to the anatomy. We focus on that topic later on with the thymectomy. We had different sizes, large and very small lesions, and we had clear resolution of, in all these cases, directly proven in the OR as you do that. Well, as compared with the experience of Martin Walz, which is a friend of mine, and you all know him, who published a survey of all the thoracoscopy non-robotic experience. We found similar results. We had included the more difficult cases, but I think for general recommendation, we could address these patients best with a robotic technique meanwhile. And if there should be a policy of centralization of these cases, and there should be always an opportunity, and even now in India, to send these patients to a center with robotic opportunities. So the optimal method for localization, it's important, of ectopic mediastinal paras consists of integrated image fusion, MIBI and CAT scan. Preoperative marking on the body surface of the patient allows for secure dissection inside the operation field. Highest dexterity and accuracy of mediastinal dissection, especially for complicated anatomical localizations of the PTGs, and with redo procedures will be accomplished by the robotic Da Vinci system.
Gents, that's a very nice presentation, and obviously you've got extensive experience with ectopic parathyroid adenomas. We have been fortunate with our group in Southampton. We did about 8 of these by VATS, and I've done my first one by robotic recently. Our practice is, these are very difficult to localize, as you rightly pointed out. So 2 things just to add to your talk. One is I always do a 3D reconstruction on the console with the radiologist. I sit myself and do a 3D reconstruction. It really gives you a very good anatomical orientation as to where this one lies. And number 2 is what we do is we give preoperatively just at the start of induction of anesthesia, we give IV methylene blue. And when you go in by VATS, that area lights up. I've got a very nice video where you see the whole fatty tissue and then just this thing lighting up as a blue blob. And of course, we strongly recommend you should do on table. As soon as you've extracted the tissue, you must do a serum calcium and a PTH level. And both of them ensure that you actually got the adenoma out, because it's all within the fatty tissue. Do you think that's correct? Anything else you think would help?
Yes, my question is, if you try to find the gland with a preoperative marking, with a blue, is there a time schedule you have to follow?
I usually do it the day before the 3D reconstruction.
Yeah.
I would sit down with the radiologist the evening before, and in the morning, usually these cases are scheduled first. And the PTH level comes back almost immediately. They can tell you in about
Yes.
15 minutes or so.
Yes.
So I think all these strategies help you to accurately localize, because what you don't want is coming back and finding that you didn't find the adenoma.
Yeah.
And that would be really criminal. A frozen section would be a good idea, but this particular surgery you are doing for biochemical improvement rather than histological improvement. Do you know what I mean? So the PTH is really important. If you get a sudden drop of PTH, then it means you've got everything. But yes, a frozen section is an option.
This is an interesting argument you are telling us. I know at least one publication, meanwhile, coming from the Wisconsin group, with extensive experience on that topic. Meanwhile, they omit the histological confirmation if the PTG value is down enough. And the reason for that, they state, is costs, to save money with that operation. Either to have the confirmation, or better, to show the resolution of the problem, is the PTG value coming down. You might, with only if you would leave the PTG estimation during the operation, you might have an additional gland anywhere, and the problem would not have been solved. But they leave the pathological confirmation in the cases where everything is very clear. With a PTG, it's approval of the resolution.
But, any questions from the floor?
Would you recommend a scintigraphy for all these patients?
Yes.
Yes.
Most of them present to the ENT surgeon.
Eh,
They don't come to the thoracic surgeon right away. It's usually the ENT surgeon who first sees them. So I don't know how many of them would be, aware that they should be looking for the.
We are. You are right. The way of these patients is variable. The patients with a secondary hyperparathyroidism usually come from the nephrological department, and the primary hyperparathyroidism patients, in our experience, come from the endocrinologists. This is, but nevertheless, ENT is.
If you read the literature of parathyroid dissection, mediastinal ectopic parathyroid, and Jens also pointed out in his own series and in our series as well, you'll find a number of these patients have had negative neck exposure. Okay, a very large number. And the reason for that is that most of the ENT surgeons, they will go in the neck without any imaging done below the neck. And that is the reason why they miss out on these ectopic adenoma. And that's why they come back for redo surgeries. And you're absolutely right that these imaging should be done in all patients. It should be made mandatory.
Regarding referrals, I've had few referrals from my experience would be maybe around 12 cases of parathyroid for the last 7 years. But then I'm telling you, I've had few referrals from orthopedic surgeons as well.
Is that correct?
Yes. And one from, I think, definitely from an internist and ED surgeons and all general surgeons. definitely, sir. But the orthopedic surgeons had two referrals.
Oh, wow. They come from all over, strange places.
Actually, it depends. First of all, very nice paper, gents. Very systematic and exhaustive review and very focused kind of a description. Thank you so much. These patients, it will depend on what stage they are coming to you. They can come from endocrine. If the patient presents with typical features of hyperparathyroidism, they would be worked up in endocrine and can come from there. They might have presented with multiple. One of our patients actually was admitted to orthopedics and was being worked up there for why she is having fractures, and during the course of workup this was discovered. But as you rightly mentioned, most of them, or if not most, many of them would have had a negative neck exploration. So they are diagnosed as hyperparathyroidism, they undergo a neck exploration, it's a negative, patient does not improve, symptoms persist, and then you start looking for other localized site of this thing, and during that a detailed workup is done, and then this is detected. To my mind, the single most important step in the management of these patients is an extensive pre-op workup to accurately localize. I mean, you would agree, yes, surgery is tricky, but if you compare localization, the importance of localization versus the difficulty of surgery, I would put more money on importance of localization. If you've got it right location for somebody who's used to taking out thymomas and lung tumors, taking out the ectopic is not technically a big issue, but a bigger issue is to accurately localize. And I think that's where we often falter, that we go in, we'll see inside, and then you don't find it inside and you have negative. But as you very rightly pointed out, if you've done, and he complimented that 3D reconstruction, so you know, you have a visual picture of where it's going to be. Then you will find it, and if you find it, you will take it out. And PTH is the key thing. I mean, if you do on-table PTH and it was high, and on-table you show that there is it may not return to normal, but there would be a dramatic fall in the level. That's enough evidence. That's what we do. Frozen, of course, as Dr. Kapil mentioned, is a possibility, but may not be necessary. If you localized it, you found it where you thought you will find it, and PTH is low. I think 3 evidences would be enough to accept that we've done it.
Dr. Bakshi.
Thank you. It's a good point here. May I ask you, how many times have you got the double adenomas? Because I have a very interesting case in which it was there in the neck as well as in the ectopic location. So I did that case. In fact, in the first operation when I found the adenoma proven by frozen section and PTH, and then it was okay, and I did my, through cervical exploration only, I did the mediastinal exploration by finger technique only. Didn't go for the mediastinum because I found the adenoma, and frozen section also confirmed it. But later, after some time, again, the PTH started rising, and the serum calcium started rising. And then I did all the imaging, system AB and all, in the first time also. But in the second time also, when it started, I did the system AB again, and they were not confirmatory. 3 times in AIMS and Delhi, all other 2-3 places, the system AB scan was done. And no, they were suspecting, but not very clear. Then I did a CT angiography, and CT angiography also showed a very mild area of this thing. Then I did a PET CT, which was also not very able to tell me that yes, it's definitely an adenoma. Patient was a case of carcinoma breast as well. So they were not very much the thing whether it's a node or it's something else. So at that time, then I did the re-exploration, and I found another mediastinum. I did because I was not very sure that if I do it by thoracoscopy, I'll get it. So I did it by partial sternotomy, and I got the adenoma, and finally the patient is fine. So maybe sometimes you encounter such cases as well. How many times have you got?
Very interesting comments. I try to keep in mind my comments now at first. I have to ask you, was that really a double adenoma? It's very interesting. In most of the cases, we expect to have more than one gland hyperplasia then. This is my experience. And that I had, let's say, maybe 10 times. It's not very, very frequent finding. But two adenoma glands is a very rare case to be published. And again, you are perfectly right that, as you saw in these cases, you may have a apparent resolution of the problem with one of the glands being taken out with a PTG control.
Yes.
And within 6 months, or was that after 6 months in your case?
No, it
Nevertheless, again, in hyperparathyroidism comes in. It's maybe because one of the glands is very active and the other is to become very active, maybe like this. But I wanted to remind of all of us again, this paper in 2011 of the Columbia Presbyterian group with Joshua Sonnet, 15 patients, 3 patients not resolved. One of the conclusions is never use a thoracoscopic approach as exploration method. Never do that. If you have this was the conclusion, if you have no confirmation of the localization inside the mediastinum, don't go into the mediastinum then. The second thing is we all as surgeons are a little bit under pressure from the history. Why is that so? Because there have been important investigators, important doctors, scientists telling the story like this, like the radiologist Churchill did. As a radiologist, he said, the most important localization in the hyperparathyroidism is the localization of a capable surgeon. Meaning, the surgeon has to go in and resolve the problem. You don't have to do too much as the endocrinologist in these cases. This has been such a saying, not coming from the surgeons, but putting many surgeons under pressure, because I know that a lot of endocrinologists, not because they are lazy, but they really think the surgeon has to come. He has to find it. And this may be true in the majority of the cases, but never in the difficult cases. And again, as to the scintigram in the neck is difficult. I had the chance to be part of the German Society of Nuclear Medicine when they tried to focus on the right schedule to perform the best technical way of parathyroid scintigram. It has been and it will be difficult until now. And I require not the scintigram before any kind of hyperparathyroidism operation, because I want to see anything in the neck. I only want to see if there is no ectopic mediastinal gland. In my opinion, in the neck, we have, on various occasions, we had a localization of the gland by all these means, and it was quite in another place. Is that, I give that to you for discussion, is your concordance with a neck localization diagnostic, is that really very valuable in 100% of the cases? I had several glands, they were swearing, this is the sonogram, this is the scintigram, there it should be localized on one side. We took a small incision, and we found it at the other side. This may happen in more than 30% of the cases, again, depending on the skills, experience, and on the case itself. This is one question for you. And my last point now is, well, the three-dimensional analysis of the gland, all that is very, very necessary, valuable, but my point is, in the different cases I showed, the point is to find it again in the operation field. You might have the best three-dimensional imagination, but where is it in the patient in the OR field? This is another question. The intraoperative localization is another thing as compared to the preoperative localization. And if you ever were in the OR and you said, well, I had the imagination, there it should be, but where exactly is it now? This is the point. Thank you.
Thank
and
you.
the question to you.
Thank you very much, gents. That's really a superb presentation with